Hello to everyone. I have the pleasure today to welcome Professor Louis Vincent, who has been my head of department and chair of the ISICEM, because we are less than 2 weeks from the ISICEM number 40. So Professor Vincent, how is it going?
Well, Fabio, we are together and we organize it together. But we know it's going relatively well, actually. Virtually all faculty members will be there. Of course, there are a few missing from countries which are far away. But from North America and Europe, virtually all speakers are coming. So I think we'll have an excellent program, and we have quite many participants. Of course, less than usual, many from Europe, not so many from other continents, but there is a lot of good stuff that will be discussed. Fabio, go ahead.
This will be probably the first big critical care meeting after the onset of the COVID pandemics. My first question would be, many participants, of course, are there at the opening session and they listen to the studies being published concomitantly to the meeting. Can you tell us something which should we expect from the opening and from the other days of the meeting about these new studies?
Yeah, we will not have a formal opening session, primarily because it's a bit difficult to enter the big auditorium with the sanitary measures. So we preferred, to go directly in the 10 different rooms of the Congress Center. But yeah, we have several new trials that will be discussed. One is the big meta trial on prone position in ARDS. Meta trial, you will see what it is. It's not a meta-analysis, and it will be published concurrently in the Lancet Respiratory Medicine. Then we have some papers in the JAMA. The paper from the man from the Netherlands on low normal versus high normal PaO2s in acutely ill patients. And the other one, also in the JAMA, will be the results of the REST trial on extracorporeal CO2 removal. We have already discussed and presented these data at our recent virtual meeting. And then, of course, we'll discuss the results of the Zampieri study from Brazil on, on saline versus balanced fluid. But let's come back to that in just a moment. There is a paper almost accepted in the New England Journal from the recovery platform on CPAP versus high flow oxygen administration in COVID-19. So that will be interesting as well. There will be papers on COVID and papers on, of course, on other diseases. We don't want to focus only on COVID. But if I may, Fabio, before you continue, because there will be also discussions on TTM and cardiac arrest trials, but an interesting session will be around the implications of COVID-19 to other sepsis cases. Shall we be more liberal with the administration of corticosteroids? What about anti-IL-6 strategies? What about coagulation management, etc.? So there will be some other implications. It's time to think about the implications of all this COVID stuff, right?
Yeah, because as you said, now we have quite few papers on, as you said, steroids, anti-interleukin-6, and the new paper on the anticoagulants. And I think that the connection, the direct connection of the faculty with the participant will raise very nice discussions about all these issues. I would like also to make you maybe another important question. You mentioned a lot about randomized clinical trial, which drive most, but not everything about our practice. But you also have some session, and I know that you like it, about personalized medicine. Can you tell us something about the program and maybe some example on how personalized medicine does not match with randomized clinical trials in our daily practice?
Yeah, there will be quite a bit of discussion around this, including, the sepsis bundles that our North American colleagues like so much. It's just ridiculous to think that we need to treat all patients in the same way, the same amount of fluids. We need to individualize our therapies, but it's getting clearer and clearer over time and better accepted. We are fed up with these negative trials looking at a single small intervention in huge number of patients, and the results do not show any difference. Look at the paper from Brazil, just published in the JAMA last week, on saline solutions versus balanced fluids. Of course, if you give only 1 liter or 1 liter and a half, how can you expect a difference in mortality? It's ridiculous. We know that saline solutions can result in hyperchloremia, and we know that hyperchloremia cannot be good. In this study of 10,000 patients, there is no difference in chloride levels because they gave quite a limited amount of fluids. So how could it be deleterious? And the authors conclude that this is not in support of the balanced fluid. But we need to personalize this. We cannot say that one type of fluid is better than the other. We need to measure chloride levels when we give saline solutions. And if chloride levels go up, we should stop giving saline. It's basic medicine, but people forget about the basics. They want to do big negative trials, and then they say there is no difference. Is it your interpretation, Fabio?
I think that, I like how passionate you are discussing these issues, because this is what we miss now since 1.5 years, the possibility to interact with people and maybe share some different thoughts, and again, try to interpret the findings from the results and apply them to the practice. And as you said, studies give some results, and then how we translate these results in our practice could not be exactly the message coming from the conclusion from this paper. Yeah. So maybe I will leave you the place from a last message to the people.
No, I'd like to ask you. So you will discuss the recent TTM studies as well. And so should we still use hypothermia after cardiac arrest, or is it now over? Or should we just avoid hyperthermia and that's it? What is the interpretation?
So the interpretation is, should I prefer cold temperature like you have now in Brussels, or hot temperature like I have here in the south of Italy? Well, I would say from holidays, maybe hot temperature is better. From temperature control in cardiac arrest, it remains complicated. I was part of a TTM2 trial, which was very, very nice paper. And maybe, as you know, we have prepared a commentary, which has been even cited by critical care reviews, like the article of to read of the week, where we tried to give some insights about how TTM2 results could apply to daily practice in managing cardiac arrest. It still remains controversial from some. It's still very clear from others. So I'll be very happy to share my thoughts with people in the audience during ISICEM in a few days.
Yeah, it's important to say that we really wanted to go back to a face-to-face meeting, because we clearly need these interactions, pro and con debates, roundtable discussions. People really are starving for this kind of direct discussions. And there are still some people who say, "Oh, I'm sorry, it's so difficult to travel. Could we have something, in the form of video conferences?" No, that's not what people want. We have enough of these video conferences, and we can now see the pendulum swinging back, and people say, "No, we want to return to a face-to-face meeting." And that's how you started our discussion. By saying that we have the first after COVID meeting. I know it's not over, COVID is not over, but for people have to get vaccinated, and we need to go back to a normal life and travel and have these discussions again, don't you think?
Absolutely. I think with these very, very wise and full of hope words, I hope to see you maybe soon, because I will be back in Brussels tomorrow.
I hope
And
you
of
are not
course,
in a red zone. I hope you can come back to Belgium without any difficulty.
no problems. And of course, we will welcome together people in Brussels in few days. Thanks a lot.
Absolutely. Good to see you, Fabio.
Bye-bye.
And of course, all people who are watching us. Take care.
Take care. Bye.